series of webinars focusing on the Vessel Health and Preservation Initiative. Following our presentation, we welcome your questions. Feel free to submit them throughout the session using the questions pane of your GoToWebinar control panel. This webinar is accredited for 1 contact hour for nurses and respiratory therapists. The title of today's webinar is What is the Right Line for the Right Patient at the Right Time? Speaking on this very important topic is Ms. Nancy Moreau, CEO of PIC Excellence. Ms. Moreau is a highly sought-after speaker on peripherally inserted central catheters and issues of vascular access practice. Ms. Moreau began her nursing practice in 1981 and is currently part of the PIC IV team at Greenville Memorial Hospital in Greenville, South Carolina. She provides educational consulting, program development, and speakers bureaus in conjunction with PIC Excellence. She is continuously involved with research and literature analysis and shares her expert opinion on PIC lines, ultrasound and vascular access with manufacturers, hospitals, and individuals throughout the U.S. and abroad. Ms. Moreau has disclosed the following. She's with the Speakers Bureau for Arrow Teleflex, Cook, Excelsior, and 3M. She provides educational support for Access Scientific, Angiodynamics, and Genentech. At the end of this webinar, you can obtain 1 contact hour by going to www.saxtesting.com/VH. There, you can complete the post-test and evaluation form. Upon successful submission, you will be able to print out your certificate of completion. The provider, Sax Communications, is approved by the California Board of Registered Nursing, provider number 14477. This program has approved for 1 contact hour of CRCE by the AARC. No off-label use of products will be discussed. Ms. Moreau did not disclose any conflicts of interest in relation to this presentation. And now, please welcome Ms. Nancy Moreau.
Hello everyone. It's a pleasure for me to come and present for you today on the concepts of vessel health and preservation. What is the right line for the right patient at the right time? We'll be discussing key concepts of vessel health and preservation, talking about the benefits of vessel health and preservation in the program form, and describing the implementation plan for you to effectively use vessel health and preservation. We'll talk about the tools with the Vessel Health and Preservation Initiative, including the Daily Vascular Access Assessment Tool. And then, in conclusion, we'll identify methods for providing input and evaluation into a program where you apply vessel health and preservation. So what is vessel health and preservation? The Vessel Health and Preservation Program is a process that incorporates a number of factors, including evidence, guidelines, assessment, and application of all of these issues to create a process that effectively promotes device selection, insertion, maintenance, and removal that is all patient-specific. Vessel Health and Preservation is an evidence-based system that functions with a timeline beginning with a patient's admission into acute care through their discharge, applying a selected algorithm that promotes a device selection process that is individualized for the patient. The results that we hope for with vessel health and preservation is providing each patient with the right line specific to the right patient at precisely the right time. So when we look at vessel health and preservation as a vascular access system of care, we'll recognize the timeline that incorporates admission, assessment within 24 to 48 hours of that patient admission, and then device placement within that same time frame. For every day that the patient is in the hospital, they'll have a daily assessment that will help to look at the concepts of, is the device still the most appropriate one for the patient? And is the device still necessary? Maintenance, education, and concepts of best practices are incorporated into the implementation plan with vessel health and preservation, helping to bring all the staff, both nursing and medical staff, on board with the concepts of best practice. Device removal is reviewed on a daily basis as part of the daily assessment tool in order to help both nursing and medical staff to make a clear determination each and every day on whether that device is still necessary. And if it is, how much longer do they estimate that device will be needed? And then as the patient is discharged, evaluation is done from the patient point of view and from the clinical staff point of view in order to identify areas that can promote improvement and customization for the whole process for your specific facility. Vessel health and preservation is designed to improve the outcomes for vascular access and promote better patient satisfaction for the whole process of vascular access. Vessel health and preservation outcomes are a function specific to the evidence and guidelines that are applied. The concepts that have been incorporated into vessel health and preservation include the selection of the best vascular access device based on the treatment plan and based on reducing patient risk. The fewest lumens with the smallest size, safest location, and use of ultrasound are all incorporated into the educational plan and process with vessel health and preservation. Right patient concepts are applied with the selection of a device based on patient-specific conditional factors of acuity, of comorbidities, and other specific long-term needs that that patient may have. Each patient is assessed in regards to their veins, the health of the veins, the best vein that may be chosen in order to insert the device, and then other historic factors that may impact your choice of a device for that specific patient. The right time concepts are applied early in the patient's admission process with early assessment within the first 24 hours and then placement of the device specifically chosen for that patient within a 48-hour time frame. Daily assessment helps to determine if that device is still the most appropriate one, and then it promotes removal of the device in the earliest time frame to help to reduce patient overall risk. The Vessel Health and Preservation Program is designed as a protocol, similar to protocols such as myocardial infarction protocols, heparin protocols, other types of protocols that are automatically applied within your hospital setting. This helps to empower the nursing staff as well as assist the medical staff in having vascular access that is uninterrupted, maintained for the patient with the least number of complications. When used as a protocol, the Vessel Health and Preservation Program is instituted as soon as the patient is admitted to the hospital as an intentional process rather than a crisis management process that is the norm in most of our hospitals. When the protocol is instituted, the nursing staff is encouraged to start the assessment process with each patient within that 24-hour time frame to fully assess the patient for their vascular access needs, taking into account condition, acuity, veins that are presenting, their historic factors, as well as other aspects that may be patient-specific in terms of patient preference. As the Vessel Health and Preservation Protocol is implemented, all the factors and tools are applied to help that patient to get that device as early as possible within their hospital stay. As you can see from this flow chart, the process starts with patient admission, goes through implementation of the protocol with assessment, initiation of the device, and then moving into the other tools that include the daily assessment and the complete process for vessel health and preservation. As an ongoing process, the patient assessment is done and determination of device necessity is a function of the nursing and medical staff each and every day. Once the patient is discharged, evaluation tools help us to analyze whether the process actually worked for the patient and whether it's working for the facility as a whole. So what are the benefits of vessel health and preservation? This protocol helps to apply a new culture of care for patients with vascular access. Historically, patients are admitted to the hospital, a short peripheral device is inserted, and no one thinks about vascular access until problems develop. Well, what a novel concept to think about the process of vascular access before we start, or at least within the first 24 hours, in order to avoid those complications and really place the best device for the patient. If a patient has the device that's most appropriate for them, it does promote a consistency of care and one that allows them to receive their infusion treatments consistently, as ordered, and help them to reach their highest level of healing quickly. An intentional selection process helps to preserve patients' veins instead of burning them all out one at a time and going to another. It helps to reduce the number of attempts that are done with each patient, thus increasing patient satisfaction. Vessel health and preservation takes the best practices, the evidence, and the guidelines and incorporates it all into the intentional process rather than deciding which best practices should we work on today or how can we incorporate the bundle practices for insertion as well as maintenance practices with our evidence and recommendations. Vessel health and preservation attempts to incorporate all of those factors not only into education but into the application with the individual patient, all of it done on admission and throughout the patient's stay. Education and compliance with the guidelines are also a part of vessel health and preservation to measure whether or not the processes are being followed. Also incorporates in annual education for the staff that's specific to vascular access, which is part of the recommendations for the Society of Healthcare Epidemiology of America, the SHEA guidelines, as well as helping to promote fewer vascular access devices that certainly makes every patient happier. Well, when you think of vessel health and preservation, where do you actually start in order to incorporate this process into your hospital and change the culture? The implementation process for vessel health and preservation is not a real simple process. It's not like, let's just use this one form and we'll be done. It is a thoughtful process that must be incorporated in order to change the whole culture of how vascular access is done from facility to facility. It does require a commitment on the part of the hospital in order to slowly phase in the different aspects of the intentional process. So with the first step of implementation with vessel health and preservation, each facility needs to look at their processes and determine specific gaps and needs that are specific to vascular access. Look at their patient satisfaction scores, complication rates, number of devices that are used, various types of guidelines that have or have not been applied, and compliance with those guidelines and processes. Looking at the policies and procedures, the need for change, and how education is done now. After all of these concepts are reviewed and gaps are analyzed, then you can determine on a custom basis which type of tools and processes you need most and determine whether the entire vessel health and preservation process and protocol will be applied. After the hospital looks at the gap and needs analysis, then it may be possible to select a particular unit that either has problems that need to be resolved or the unit is particularly enthusiastic about change. You want to choose a unit that has a commitment to making change and is willing to go through the process on a month-by-month basis in order to trial the process and tools, help to incorporate them into your electronic process if that is your experience at your facility, and simply to help to roll in the program on a phased process. Once the unit is selected and they've gotten a buy-in for the program, then the process of education can occur. The first phase of vessel health and preservation incorporates education of inserters, both nursing and medical staff, working together with the unit staff to help to educate them on the first tools that they choose to apply. And that can be done differently for different hospitals. Once the process of implementation is phased in with the tools and the process is started with the unit, then you're able to look back and see compliance rates that help to guide you into each of the next phases. The whole process of vessel health and preservation is designed to help to promote better communication between nursing and medical staff specific to vascular access, also including the patient and empowering them on many of the concepts of education for vascular access and infection prevention. Once these processes are applied, then evaluation is ongoing, both from the patient perspective and from the clinician perspective from unit to unit. Medical staff is encouraged to give feedback, and customization goes on so that this whole wheel continues as you apply it per unit and then per entire facility. The first phase of vessel health and preservation focuses on gaining the information that you need to know areas that require attention. Performing a retrospective review of vascular access device usage and complications is part of the gap and needs analysis. Once you have effectively pinpointed areas of need, then the education can be customized to include additional points that may be specific to your facility, or simply to use the vessel health and preservation education as it stands now. The education in Phase 1 is initiated generally focusing on the daily vascular access assessment tool. With the beginning use of the assessment tool, the focus is on measuring compliance with the tool, seeing how well the nursing and medical staff complete the process, gaining their feedback so that the form can be customized and applied to the facility, helping to work with the information technology or IT department in order to incorporate it into the electronic medical record as appropriate. And then, as the process continues for Phase 1, there's a random trial use of the admission assessment tool, or the trifold as we sometimes refer to it, that is the complete assessment for patients that will be part of Phase 2. The patient and staff are continually evaluated for comments and satisfaction, which helps to provide feedback to the facility on the value of this vessel health and preservation initiative. The overall process in Phase 1 for vessel health and preservation initiation is focused on helping the staff to feel the value of this program so that they can be completely engaged in the process going into Phase 2 and then later Phase 3. The retrospective review is a vital key in order to show the staff that improvement is possible in step-by-step fashion. And then the retrospective analysis will be used to apply to the prospective analysis and improvement in Phase 2 and Phase 3. When we look at each of the processes for vessel health and preservation, the right time for the right patient at, the right line for the right patient at the right time, the Phase 1 starts with the right time, helping to apply the concepts of our guidelines and recommendations that show that we need to determine whether the device is actually necessary. The daily assessment helps to look at patient-specific factors, complications, functions of the device, health of the vessels, and then help the clinical staff determine each and every day whether that device is still necessary. Many facilities have applied the insertion bundle, the central line bundle of practices, but what I find in my experience is that the majority of them apply 3 out of 5 of the bundle practices. And while most say that they are applying the bundle, there is inconsistency in how device necessity is being determined, and generally a lack of documentation on this process. Vessel health and preservation helps to show that there is not only compliance with review for device necessity, but also documentation of this process and demonstration of communication between nursing and medical staff. The daily assessment tool that you see here is part of the process for the determination of that device necessity. It helps staff to look back over the last 24 hours and determine if there were any complications within that time frame specific to vascular access devices. Ideally, the nursing staff completes the first section of the form before 6 a.m. so that the tool is ready for the medical staff with their early morning rounds. The medical staff then looks over the lower portion of this assessment tool, helping to determine whether the patient can switch to oral medications. Is the patient still experiencing bloodstream infection and requiring medications for that? Will access be required when the patient is released or discharged from the hospital? And then kind of a determination of what the discharge plan is, how many days that are left. All of this helps to give the nursing staff an idea of what the plan is for the patient in order to help to work ahead and be prepared for the patient at their time of discharge. The medical staff then determines if the device is necessary and, if still needed, estimating a certain number of days so that each and every day you can look back at the assessment tool to determine necessity and how many days are left. The daily assessment tool helps to promote daily rounds that focus on vascular access. An incorporation of goal evaluation and device assessment helps us to make sure that the patient is receiving exactly what they need and not placing them at risk with a device that's not necessary. The determination of complications helps to decide whether that device is still the right device. If multiple complications have occurred within 24 hours, then that helps us to recognize that this device is not necessarily performing the functions as it should be for this patient, and that we may need to select another device. Especially if complications and other comorbidities occur, we may need to switch over and have another device inserted. Some patient-specific factors are also measured specific to the comfort of the patient. Are they happy with the device? Is it working for them? These things are necessary for patient satisfaction, but also to empower the patient in their health and healing processes. We want to make sure that they, in fact, are able to use the device in a way that works for them. Does the device accommodate the treatment plan without interruption? And is the device still needed? And if so, how many more days? All of these factors are incorporated into helping to determine if the device is the most specific one and working for that patient throughout their length of stay. The daily assessment tool is broken up into a format that incorporates the situation, background, assessment, and recommendation as part of the SBAR format that is commonly used in nursing documentation. This includes the patient input and reason for the vascular access device that is frequently part of electronic documentation. The patient assessment and measurement of comfort and satisfaction is part of the measurement of patient satisfaction used in hospitals today. So specific to the device, we want to know that it is in fact the right device each and every day as part of the daily rounds. You can see here that the measurement of complications is incorporated into the daily assessment tool, double checking with the medical records and making the clinical staff be more aware of talking with each other to determine what complications were present. I find that in documentation in the medical record, complications are frequently missed, and so helping staff to be aware of the need to pass on verbal communication and also to identify things that have happened within the last 8 hours, within the last 16 hours, are all necessary in order for us to have a clear determination and picture of what's going on with that patient. We want to know if that patient is eating and drinking well, because this certainly affects their need for continuous infusions of fluid. Are they receiving any medications intravenously? Have they gotten anything within the last 24 hours? Or are they simply getting PRN medications as needed for pain control or other things? These all help us to know whether this device was actually necessary or is just being maintained for convenience, which is too great a risk for the patient. So removing the device as early as possible is necessary to help to reduce patients in our ongoing process to help to eliminate complications and allow infection rates to go to zero. The nursing recommendation that should be read by the medical staff focuses on whether the device is still the most appropriate device, whether this device should be maintained from a nursing perspective, and what the actual recommendation is from the nursing staff. This information then flows into the progress notes and into the physician's communication so that they can determine whether the device is necessary on a day-to-day basis. Guidelines are consistently incorporated into vessel health and preservation from the Centers for Disease Control, the Joint Commission on Accreditation, the Institute for Healthcare Improvement, the SHEA, Society of Healthcare Epidemiology of America, Compendium and Strategies for Reduction of Central Line-Associated Bloodstream Infection. As you can see from these 3 columns, these are specific recommendations that have been incorporated into vessel health and preservation to help to reduce risk of the patient and to promote compliance of these guidelines within the facility function. So with vessel health and preservation and moving forward, how do you apply it and what are the basic concepts? For initiation of the vessel health and preservation protocol, utilizing the protocol order set helps to truly make it a protocol and one that can be initiated with or without a physician's order. If your facility is able to process the vessel health and preservation protocol through the various committees that are necessary to approve and incorporate a new protocol, then you may be able to use the vessel health and preservation process as one that can be applied without a physician's order. In the beginning phases of implementing vessel health and preservation, it is likely that you'll use this order set and have it signed by a physician until the facility has incorporated it as a full protocol. This helps the whole vessel health and preservation process to be initiated immediately upon admission and directs the process to apply the tools that are necessary in order to fully apply vessel health and preservation for each and every patient. In the second phase of implementation with vessel health and preservation, the focus is on admission assessment and making sure that the right line and device are selected for the patient. With device assessment, the assessment process incorporates specific patient aspects including diagnosis, acuity in their condition, the treatment process and plan, and then the duration that's expected for that patient treatment process. All of these points help us to select the most appropriate device with the lowest risk for infection, especially including using the least number of lumens and the smallest device. Many of you that are listening today are already experts in this process and automatically include these facets of device assessment just intuitively in your determination for what device is best for the patient. Vessel Health and Preservation attempts to educate all staff, including bedside staff, in selection of device and in assessment and review of the device to make sure that the patient has the best vascular access device at all times. And so, while some of this may seem like things that you already know, we want to make sure that all the clinical staff, nursing and medical staff, is aware of the processes and how this can be done in order to assist the patient towards better patient safety. In the second phase, where the admission assessment form is applied, you can see here this 3-column form that we call the trifold. While it may look daunting at first glance, the primary area for assessment is in the far left-hand side where you see Vessel Health and Preservation Right Line Tool. This is an algorithm that incorporates individual evaluation of the patient, helping to identify their disease process, condition, and those factors that are patient-specific that help lead us to selection of the best device. Now, while ideally it would be nice to have only one device selected for each patient, it's impossible to make it a precise selection, but we have done our best in order to incorporate a variety of factors that help lead you to one specific device. Things may differ for each patient, and so when you look at the center section that talks about right line contraindication tool, these are factors that may change the type of device that is used that are based on patient-specific contraindications. There are tips that are included in both of these sections that help to guide us to the best device selection. The last column for risk factors will be dependent upon each facility and how each of the devices are inserted, meaning which clinician is responsible for the insertion of PICC lines or central venous catheters or ports, or which other device may be selected. In certain facilities, it may be possible to look at the patient's condition in stage 1 and stage 2, as you see here, and determine that they're a higher risk patient, and thus call for a vascular access consult immediately. The vascular access team may be responsible for performing this admission assessment, or it may fall to the bedside staff. It depends upon the facility and how each facility chooses to apply this admission assessment. In the stage 3 determination of risk factors, in that final column, it's determined that the patient may need to go to radiology for placement because that's been done in the past, or because they have comorbidities that necessitate radiology or a surgeon to assist in the process of a placement. Once the admission assessment form is completed, then a device is selected and the nurse is empowered to facilitate the process of placement, making sure that whichever department is in charge of that specific device is notified and insertion is facilitated within that 24 to 48 hour time frame. Specific factors for the right patient assessment include those individual patient assessment points of acuity and condition, the risk factors that are specific to that patient and their vasculature, as well as their history of device placement. Many of our patients are chronic patients and what we call frequent flyers, and they may have some specific characteristics or points that we have to take into mind as we determine which device is most appropriate for them. We want each selection of the vascular access device to be individualized so that it makes sure that it works best for that patient throughout their course of treatment and has the least amount of risk for them. With risk factors in history, some of the issues that we'll look at for that particular patient are skin conditions, vein size and health of the veins, whether they've had cancer or chemotherapeutic agents administered before, also steroids that may change the nature of their veins. Cancer patients with metastasis or tumors have a higher risk for occlusion and thrombosis, and so we may need to take those into account as you choose the best device. Patients that have renal failure must have vessel-sparing protocols in order to determine which device is most appropriate for the longevity of their life. For circulatory and stroke patients where impairment is present, device selection may have to be tailored specific to that patient and what is available considering the extremities and other factors. Surgical situations like mastectomy patients or those patients that have had multiple trauma that have affected their chest or arms or other areas will certainly impact your selection of the best vascular access device. Incorporating all of these factors, when we find many risk factors with patients, this helps us determine that there should be a specialized assessment of this patient, potentially by a vascular access team member. This helps us to effectively move that patient into that area of assessment that will work best for that patient. Considering risk and how it applies to each individual device, this is a simple tool that helps to show lowest risk device up to the highest risk device. And while there may be some discussion about which device is positioned where along this risk timeline, understand that certain devices do carry higher risk and is part of the central line bundle process for selection of the lowest risk device. With the right time assessment for insertion, the goal is to insert the device that's chosen within 24 to 48 hours of the patient beginning their treatment plan. Incorporation of risk reduction strategies like the use of ultrasound guidance for insertion of PICCs or other CVCs is necessary for this entire process. With vein assessment, visual inspection is helpful, but ultrasound assessment helps to give us more information about vein diameter and the selection of the best device that it will result in the lowest complications. By determining the catheter-vein ratio, we're able to effectively determine the device that will result in the least amount of thrombosis or other problems for this patient. Catheter-vein ratio is best done in the native state or without a tourniquet on the arm or extremity. And then the right time also incorporates removal of the device within the most appropriate time frame, never leaving a device just for convenience, and understanding that devices can always be reinserted, with the exception of our renal patients that may need to have vessel-sparing processes. With vein assessment, using observation, history of the IV access device, and then performing the ultrasound scan, this all helps us to determine the best catheter-vein ratio. When you look at different types of catheters and insertions, we have to recognize that PICCs have had a fairly high rate of thrombosis in the most recent time period. And so putting a greater emphasis on selection of the smallest size catheter with the most appropriate sized vein will help us to reduce this complication. If using a triple lumen catheter, then the vein size will need to be at least 6 millimeters in diameter, if not more. This allows for the maximum amount of blood flow around the catheter and helps to minimize complications such as thrombosis. As you can see with the 5 French and 5 millimeter, 4 French and 4 millimeter, these would be minimal vein diameters, and hopefully the patient will have larger diameters. Also, these are determined without a tourniquet in place. Admission assessment and device best practices incorporate the use of the smallest catheter, the shortest device, and the least number of lumens, all in an effort to reduce risk for the patient. We want to move from the lowest risk device to the higher risk device, but only as needed for the patient. And that's not to say that we want to maintain a short peripheral line for a patient that will be receiving treatment for 5 days or longer. We want to incorporate the best device, preferably and ideally one device for the patient's full length of treatment. Taking into account the prescribed therapy, the types and number of medications, incompatibilities, and other factors will also help us to determine the required number of lumens, or that number of lumens that will best suit the patient. Also, knowing whether the patient will be receiving treatment only in acute care or whether they'll be going home also helps to determine the number of lumens that are necessary. By considering irritating medications, whether the patient will be receiving vesicant or chemotherapeutic agents, all help us to apply whether a central venous catheter would be best for each individual patient. Additional information on device selection can be found with the Registered Nurses Association of Ontario at their website, which is an excellent guide for education and selection of devices. How do we put all the concepts of vessel health and preservation together in order to change this culture of one that focuses on vascular access from a crisis model to vascular access as an intentional selection process? Well, putting it all together from a patient and a clinician point of view takes feedback. We have to be able to evaluate how the processes are working from phase 1 to phase 2 to phase 3, and part of that incorporates feedback from the patient and from the clinician level. Being able to get comments from your staff as they're incorporating the different phases will help you to customize this entire process. Yes, it will take a commitment of the facility and a commitment of different parts of the staff in order to make all this work in a manner that is ideal for the patient. Completing the evaluation sheets, turning them in to a point person or shift captain, and then evaluating the results will all help to make the vessel health and preservation program more effective. Patients should have an evaluation completed prior to their discharge in order to give you feedback on whether they thought that the evaluations and vessel health and preservation process was helpful for them. This can be particularly effective for patients who have been in the hospital multiple times and may not have had vessel health and preservation applied on earlier hospitalizations. In and of it all, we want to get more feedback in order to help to improve the process and then move it from the selected unit into a phased process that applies it throughout the entire hospital. The total value of vessel health and preservation helps to make improvements in your hospital process, an improvement in the way the patient views the process of treatment, infusion, treatment application to help them to get better. We want to know specifically if vessel health and preservation did what it was supposed to do. Finding out from the clinical staff and from the patients whether the vessel health and preservation program provided a fast decision for the best device, if it resulted in fewer accesses for the patient. Were you able to determine device necessity each and every day? Were the forms completed, and was there compliance with the central venous catheter insertion checklist? Did you receive evaluation of complications and the information that was necessary on the daily evaluation forms? Did vessel health and preservation result in better multidisciplinary communication that we know from research results in better outcomes? And then, was the education applied well, and did it promote compliance with the guidelines, resulting in lower infection rates for all vascular access devices? Each and every one of these points helps to demonstrate value of vessel health and preservation and helps the clinical staff to understand that it really is worth the effort. With vessel health and preservation, it helps to result in better outcomes and build that into your most effective vascular access program. By looking at the retrospective and prospective information, you can go through each and every stage and demonstrate value of vessel health and preservation. The analysis of that data will help to demonstrate outcomes and specific factors in vessel health and preservation that promoted improvement. The treatment process is shown throughout the retrospective and prospective analysis as being completed without interruptions and will frequently result in a reduced length of stay for the patient and savings for the hospital in terms of cost. In the end, the most important thing to us is better patient satisfaction and better patient safety. That is the foundational concepts of vessel health and preservation and what we're trying to promote. So as you think about implementation of vessel health and preservation, think about these individual steps in the process and where you'll begin. How will you convince your hospital or gain acceptance and support for vessel health and preservation? Is this something that your hospital would like to apply that could help to promote greater quality for your patients and your overall facility? Are you able to get enough champions in order to perform a gap in needs analysis? Is the hospital, from the administrative staff down, supportive of applying vessel health and preservation, selecting the unit, phasing in the concepts, and working on this program over a period of months? You'll have to make those determinations yourself and help us to understand whether vessel health and preservation is the right thing for you and your facility. We fully expect for vessel health and preservation to result in the establishment of an evidence-based process that can be used for patient assessment and device selection, resulting in reduced risk, preserved vessel health, and evaluation of vascular access devices for necessity from hospital admission to discharge. This is our aim and this is our goal. Vessel health and preservation promotes patient safety. As part of the handouts and information that you'll be receiving, there's a list of references here that support the Vessel Health and Preservation Program. I will say that this is an abbreviated list because this entire program was developed with evidence base. Each and every recommendation that was used within the Vessel Health and Preservation has a lengthy list of references and evidence that supports each of the processes. I thank you for your time and for your attention for Vessel Health and Preservation and helping to make this a culture change and something that will promote better vessel health for our patients.
Thank you so much, Nancy. We're going to go through the continuing education credit details, which will also be emailed to you, and then in the time we have left, we will do a question-answer session. So for continuing education credit, go to www.saxtesting.com/VH. Complete the post-test and evaluation form, and a certificate of completion will be issued immediately. The provider, Sax Communication, is approved by the California Board of Registered Nursing, provider number 14477. This program has been approved for 1 contact hour of CRCE by the AARC for respiratory therapists. And again, the above information will be emailed to you following this webinar. So we do have a few questions from the audience. So Nancy, if you're ready, I'm going to jump right in. Lots of attendees want to know if the daily assessment tool you mentioned is something that facilities can print off and use.
Absolutely. The Vessel Health and Preservation Daily Assessment Form is a tool that can be provided to you. You can contact your Teleflex representative for your area in order to gain the Vessel Health and Preservation packet of information that includes the daily assessment form. I do encourage you to consider Vessel Health and Preservation, though, as a complete process and rather just as a handy-dandy tool that can be applied today. As a process, Vessel Health and Preservation results in improvements in a variety of areas. By just using the daily assessment form, you don't receive the full benefit of all the value of Vessel Health and Preservation. And so while Teleflex is glad to provide you with the forms and information, I do encourage you to think about it as an overall process that should be applied.
Great. The next question, how do you feel about infusing 3% NS in a midline?
Well, midline catheters are certainly an area that brings a lot of debate. When we look at midline catheters, application of the Infusion Nurses Society of Standards comes to mind, specific to osmolarity and pH. When you're looking at 3% normal saline, it can be an irritating solution to go through a midline catheter. The terminal point of a midline catheter is the proximal point of the extremity, frequently in a fairly small vein, and while we may use the basilic for the midline catheter, it's still a vein where irritating infusates will cause changes within the vessel wall and promote thrombosis. If we are constantly making sure that we are not promoting complications, then use of any type of irritating medications or solutions should not be done through a midline because we know they will result in complications. For irritating medications such as 3% normal saline, we should use another type of device where a terminal tip is in the superior vena cava, allowing for maximum dilution and least impact with the vein wall.
Okay, our next question. What is your opinion of the Chloraprep coated PICC? Do you feel it is effective in preventing infections?
Well, specific to the antimicrobial catheters and the PICC line, I think that the results that Marcia Ryder has recently unveiled at the Society for Healthcare Epidemiology of America and during some webinars that she has conducted, the 4 research studies that were done, in my mind, are phenomenal. I was very pleased with the results, and as someone who has advocated for us to achieve an ideal device, I think we may have done that. It's possible that this antimicrobial catheter does not allow attachment of bacteria or blood cells. If that is true, then we may have reached the Holy Grail. That if we have a device that doesn't allow bacteria to attach, then we don't have biofilm. Then we don't give bacteria the opportunity to grow in large colonies and grow to a strength that is very difficult for the body to overcome or for antibiotics to overcome. And so I am very positive about the new devices that have been developed, and am looking at the evidence that really shows a change. Do I have enough information to say whether they will allow for complete avoidance of infection. No, I can't say that because we're still waiting for more clinical results. But based on the research from Marcia Ryder, I am very enthusiastic. And if one of my family members needed a device being inserted, that's the one I would choose. I think it has the least risk at this point in time.
Great. Nancy, would you be able to address any experience you have had with collaborating with interventional radiology and anesthesia?
If we're talking specifically about collaboration with radiology and anesthesia for vessel health and preservation, I can say that I have had some experience with that. I'm not sure what the specific question is because there could be a lot of questions going along these lines. But are they enthusiastic about vessel health and preservation? The honest answer would be yes and no. It depends upon the departments. It depends on what their goals are. Some of the departments that I've come across have been very supportive of vessel health and preservation because they wanted to reduce their volume of line insertions and make those insertions less of a crisis issue where they're called and it needs to be placed today. They would like to have a little more running time, which early assessment helps to promote. Other groups are not real excited about vessel health and preservation because they just simply don't want change. And so working with them with education and understanding vessel health and preservation has helped to promote better support and better understanding of what all of our goals were. And that helped to change some of the resistance that I've seen in the departments. I do think it is necessary to work together interdepartmentally in order to promote vessel health and preservation, that it can't only be done on a nursing level, that it can't only be done on an infection prevention level, that it has to incorporate in radiology, nursing, medical staff on all levels, and administration in order to be successful.
Great, and I think we have just about a minute or two left, and I do have a few questions here about home health implementation. So briefly, do you have a protocol, plan, or recommendations?
Specific to home health, we haven't really gotten there yet. Vessel health and preservation was developed over a period of years, and while we initially strived to apply it to all areas of care, we were only successful in creating it initially for an acute care model. I can see that some of the tools and concepts certainly would apply to a home health situation, especially in terms of daily assessment. But I see a difficulty in getting the same level of multidisciplinary communication that we feel is necessary right now in order to be effective with that daily assessment. There are some issues, and I would be open to communicating with others who are involved in home health and home infusion in order to see how this could be adapted to be more effective for those specific care areas. I do have quite a bit of home infusion experience myself, with about 14 years, but this is a process that would need to be adapted for that specific care area.
Okay, and with that, I do believe our time is up today. So if we could just advance to the last slide. I want to thank everyone for attending our session, and again, it will be recorded and archived, and for more information, you can always check out vesselhealth.org. So again, thank you to Nancy Moreau, and thank you to all of our attendees. Have a fabulous day.
Thank you, Kristen.